Hello friends, today we are going to discuss about the HLH. This was the question which was asking the RNB critical care exam in October 2023. The question was diagnostic criteria and management of the HLH. So what is HLH? HLH is hemophagocytic lymphohistiocytosis. It is a rare phenomenon of the immune dysregulation primarily recognized in pediatric patients, and it is a relatively underdiagnosed owing to the various manifestation and the lack of awareness among medical fraternity. It can either be sporadic or familiar, generally being precipitated by triggering events such as infection or malignancy. It was first reported in 1952 by Farquhar and Clairvaux. Chemotherapy has proved very effective in controlling and curing HLH apart from the prolonging survival. It affects both gender, though a slight male predisposition is seen in adolescents. Incidence is reported to be as high as 1 in 3,000 pediatric hospital admission. Positive family history, such as parental consanguinity and the death of sibling, can be leading clue owing to the autosomal recessive nature of the inheritance. About classification, HLH is classified based on its etiology. Distinguishing primary from the secondary is crucial as management is different in each type. Primary HLH is seen in pediatric age group. Secondary is common among adult and elder. The genetic form of HLH can be divided into familial HLH associated with immunodeficiency syndrome and without any association with the syndrome. So family history may not be elicitable owing to recessive nature of the disease. Most of the genes implicated are one coding component of the perforin gene, accounting for 50% of all familial HLH cases. There exist other genetic defects in regulating packing, transport, and release of cytotoxic granules. So mutation in this gene loci and their genetic defect. So this is the table which is the representative of the number of the chromosome which is responsible for that, and according to this chromosome 9, chromosome 10, 17, 6 and 19 is responsible for HLH. So the immunodeficiency syndrome that to be associated with the HLH are Chediak-Higashi syndrome, then Grizzly syndrome, then Hermansky-Pudlak syndrome, and X-linked proliferative syndrome, also called as Duncan disease, which is characterized by the abnormal response to the Epstein-Barr virus infection. Now about the pathophysiology. HLH is the syndrome of extensive inflammation due to abnormal activation of immune cell, which results in the lack of normal down regulation of activated macrophages and lymphocytes, which then cause tissue destruction. In HLH, the impaired cytotoxic function of natural killer cells and cytotoxic lymphocyte result in faulty elimination of macrophages, leading to uncontrolled activation. So lysis of target cell is a cascade where there is formation of immunological synapse creating a pore in macrophage, following which there is exchange of cytolytic granule containing granulozyme and other protein which eventually causing apoptosis of the cell. The genetic defect occurring at various levels of this cascade in the HLH hinder the normal apoptosis, causing excessive activation of macrophages and hypercytokinin. These cytokines are interferon gamma, tumor necrosis factor alpha, and interleukins such as interleukin 6, interleukin 10, interleukin 12, and soluble interleukin 2 receptor. So elevated interleukin 16, it is important for T helper type response that recruit macrophages and other cell causing HLH. Another cause of HLH is the activation of toll-like receptor, which are non-antigenic specific receptor on the surface of NK cell that can be activated by components of bacteria, fungi, viruses, or mycoplasma. In macrophage activating syndrome, gene causing TLR and interleukin 1 receptor signaling are upregulated, resulting in hemophagocytosis. The precipitating factor is the infection in most cases. triggering an acute episode leading to immune homeostasis alteration. The most common implicated organisms are viruses, that is Epstein-Barr virus, cytomegalovirus, parvovirus, herpes simplex virus, and bacteria like Brucella, gram-negative bacteria, tuberculosis, and parasites like leishmaniasis, malaria, and fungi. Positive association between the HLH and the malignancies like leukemia, lymphoma, solid tumors has been well documented. The genetic understanding is essential for physicians to determine the likelihood of recurrence, the need of hematopoietic cell transplant, and the risk of HLH in family members. So this is the pathophysiology of HLH. So there is for because of the component of microorganism, there is activation of toll-like receptor on NK cell, which causes the induction of interferon and the pro-inflammatory cytokines. Or if there is any triggering event in the form of excessive infection and malignancy, there is impaired cytotoxic activity of NK cells and lymphocytes, which causes which leads to the inability to eliminate macrophages, and there is uncontrolled activation of macrophages which will lead into the cascade of lysis of target cell. And because of the formation of immunological synapses, there will be the protein macrophages, exchange of cytokine granule, which lead to the cell apoptosis, uh, and that will lead to the macrophage. But this there the cell apoptosis process will be blocked here, which lead into the macrophage activation and hypercytokinemia. So we'll see once again the mechanism. So the mechanism is the in hemophagocytic lymphocytosis. It is triggering either because of infection or either because of the malignancy. So what is happening in the infection? So because of the component of the macrophages, there is activation of the NK cells, which will lead to the production of interferon and the pro-inflammatory cytokines. Or other mechanism is there is impaired cytotoxic activity of NK cells and lymphocyte, and because of the inability to eliminate macrophages, there is uncontrolled activation of the macrophages, which will lead into the cascade of lysis of targets. Or there is a formation of immunological synapse, which is causing the protein macrophages. So because of this, there is an exchange of cytotoxic granule, which lead into the cell apoptosis. So this is the normal process, but which is blocked in the HLH. So that leads to the uncontrolled macrophage activation, which lead into the hypercytokine. So HLH is the basically a syndrome of hyperinflammation driven by underlying trigger or triggers. Especially in early stages, the features are non-specific. There is important clinical triad to recognize, that is three F's, that is fever, falling blood count, and ferritin. So fever is persistent and the antibiotic resistant. Falling blood counts, especially platelets, and the ferritin, which is marker of macrophage activation. Um, So the clinical features of HLH have the wide spectrum, thus arriving at accurate diagnosis is challenging. The presenting feature is generally a febrile illness associated with multiple organ involvement, that is fever, rash, hepatosplenomegaly, lymphadenopathy, edema, bleeding manifestation, icterus, liver dysfunction, neurological symptom such as seizure, altered mentation, ataxia, posterior reversible encephalopathy syndrome like picture, especially in case of familial HH. Magnetic resonance imaging of the brain in this patient can show hypodense to necrotic areas. Almost around half of the HLH patient have CNS manifestation if it is a family. If central nervous system involvement is present, there is manifold increase in the risk of mortality and neurological sequelae. Presenting with feature of respiratory problems like ARDS, hypotension, renal dysfunction, even requiring dialysis, syndrome-specific features like albinism, photosensitivity, silver gray hair like features in Shediac Higashi, Grisly syndrome are not then regarding investigation, complete blood picture is done routinely on all patients as they present with the feature of infection and with a history of infection as triggering it. It is evident that more than 80% of patients develop bicytopenia and pancytopenia. The clinical symptoms with cytopenia should lead the pediatrician to suspect HIV. Delayed onset cytopenia is the distinguishing factor in the macrophage activating syndrome, and generally these patients have elevated count prior to the development of it. Now, liver function and coagulation factor. Abnormal liver function and coagulation defect are seen in the HLH. Hepatitis is frequently encountered in patients with HLH, which is manifesting as elevated bilirubin, liver enzymes, lactate dehydrogenase, aspartate aminotransferase, alanine aminotransferase, gamma glutamyl transferase, and the low albumin. Hepatic failure seen in this patient can vary in severity from mild to fulminant. Hence, all patients with HLH, prothrombin time, activated partial thromboplastin time, fibrinogen, and D-dimer must be investigated. Now about markers. Important biochemistry marker in the HLH including ferritin and triglyceride. Highly elevated ferritin is the diagnostic feature of HLH. Hypertriglyceridemia develops secondary to the liver enzyme. Decreased fibrinogen levels are additional indicators of HLH. Elevated serum neopterin levels are observed in patients with HLH by Ibarra. They found this marker as specific and sensitive marker for diagnosis of HLH. Now about bone marrow examination. Incidence of bone marrow involvement by hemophagocytosis in HLH ranges from 25% to 100%. At times, initial stage of the disease, no marrow involvement may be seen, but may be seen later in the course of disease. However, bone marrow examination is mandatory in this patient to detect hemophagocytosis, to rule out lymphoid malignancy, aplasia, and isolation of organism if cultures are done. Varied cellular pattern of high, low, and normal cell can be noted in the HLH. Then a characteristic diagnostic feature is infiltration of the bone marrow by activated macrophages showing engulfing blood compound. It is a simpler to higher macrophage by staining for hemoglobin, hematoglobin scavenger protein receptor CD163. This is the bone marrow picture showing hemophagocytosis. About liver biopsy, lymphocytic infiltrate is seen frequently and chronic persistent hepatitis with periportal lymphocytic infiltration can be seen in severe cases. CSF analysis. Cellular pleocytosis, elevated protein, and hemophagocytosis can be detected on CSF analysis as a part of specialized testing. Several investigations, especially to elicit genetic causes, must be performed. Now about immunological profile. Underlying disease pathology can cause hypercytokinin. Thus, identifying with cytokines along with NK cells, cytotoxic cells in immunological profile has been proved useful in the diagnosis. Elevated soluble interleukin 2 receptor alpha, that is CD25, found to correlate with the disease severity. Natural killer cell function and degranulation are found to decrease in this patient. Low CD107 on peripheral blood mononuclear cell is a marker of UNC13D, STX11, STXBP2, and then RAB2 RAB27 mutation, which can be detected through hemagglutination and anti-CD3 stimulation by flow cytometry. Detection of the perforin expression on the cytotoxic T cell by flow cytometry is one of the rapid diagnostic tools to detect homozygous mutation, but with limitation of variable protein expression. Flow cytometry of cell surface expression of SAP and XIAP and SH2D1A can be used in the MIP. Increased level of hemoglobin, hepatoglobin, scavengers receptor, immunoglobulin level, and lymphocyte subset can also useful investigation in the diagnosis of HLH. Now the genetic and HLA test. Genetic analysis is not practical in all cases in developing countries such as India. However, it is mandatory in children with CNS involvement, relapsing and refractory disease, and disease with significant multi-organ involvement, children born to consanguineous parents and with positive family history. Viral titers, body fluid culture should be performed. Then clinical investigation, echocardiogram and chest X-ray should be done wherever relevant to rule out cardiovascular and respiratory etiology and involvement. Imaging of CNS may show parameningeal involvement, infiltration, subdural effusion, and necrosis. Progressively increasing transaminases, bilirubin, coagulopathy, ferritin, and CD25 level, as well as deteriorating respiratory status, are considered poor prognostic signs. Now, what is the diagnostic criteria? So, HLH 2004 diagnostic criteria is first diagnostic criteria is molecular diagnosis consistent with the HLH. Pathological mutation of the PRF1, UNC 13D, and the STX11 are identified, or fulfillment of 5 of 8 of following criteria, that is fever, splenomegaly, cytopenia, hemoglobin, that is anemia, platelet count. Cytopenia means affecting any three parameters in peripheral blood count. Either it will be hemoglobin, either it will be platelets or neutrophils. Then there will be hypertriglyceridemia, hemophagocytosis in bone marrow, spleen, lymph nodes, low or absent NK cell activity. Ferritin should be more than 500 and soluble CD25 more than 2400. Then proposed diagnostic criteria in 2009. Molecular diagnosis consistent with the HLH or X-linked lymphoproliferative syndrome, or fulfillment of at least 3 or 4 of following criteria. That is fever, splenomegaly, cytopenia, and hepatitis. Or fulfillment of at least 1 of 4 following criteria. That is hemophagocytosis, increased ferritin, increased SL2R alpha, absent or very decreased NK cell, and other supportive diagnostic feature like hypertriglyceridemia, hypofibrinogenemia, and hyponatremia. Now about H-score. H-score is the online probability calculator of HLH, which uses 9 variables. Advantages of H-score include that is validated in adult population, and it uses widely available lab marker and offers dynamic prediction of probability of HLH. The score is done on the assumption of the high pretest probability. H-score need to be interpreted with caution where known liver failure, where ferritin levels can be very high and associated cytopenia. In those patients with pre-existing cytopenia due to chemotherapy and post-BMT and reaction to intravenous iron. So, 3 clinical features are underlying immunosuppression, fever, and organomegaly. 5 biochemical features are ferritin, raised level of triglyceride, aspartate aminotransferase, fibrinogen, cytopenia, and 1 morphological, that is hemophagocytosis. A total score out of 337 is obtained with probability ranges of 99%, likelihood of HLH with score of more than 250. H score of 169 has been shown to identify HLH with 93% of sensitivity and 86% of specificity. A score of 169 or above considered diagnostic of HLH in people with the high pretest probability. Initial score of less than 169, the H score should be checked daily, and rising trend in H score should increase the index of suspicion of HH. So this is the flow chart of H score. So we need to calculate the H score. If it is more than 169, then there is a high clinical suspicion of HLH. If it is not, and if there is a clinical suspicion is high, then we need to initiate discussion with the relevant multidisciplinary regarding the need, regarding depending on the patient's need, and we need for the daily HLH screen. If there is a if H score is low and if the clinical suspicion is also low, then the repeat test, then the we need to repeat test daily. If H score is rising, then consider daily HLH screening or involve multi-specialty. If H score is not rising, static or decreasing, and but if still concern remains, we need to involve multidisciplinary team. About supportive therapy aims at addressing infection, source of infection, replacement of blood volume, and severe cases, cardiorespiratory support. The broad spectrum antibiotic, as per culture report and clinical needs, are to be administered either orally or parenterally based on severity of infection. Prophylactic therapy with the cotrimazole, oral antimycotic agents, that is fluconazole, and antiviral therapy are to be considered in patients with evidence of viral infection. Administration of IV immunoglobulin, that is 0.5 gram per kg, once every 4th week is advised during the initial phase and as per need in continuation therapy. Rituximab is to be considered for those with Epstein-Barr virus infection triggered HLH. Patient required blood volume replacement, particularly those with HLH, induce bleeding, clotting factor derangement, transfusion of blood product, packed red cells, platelet, fresh frozen plasma, cryoprecipitated, and occasionally activated factor 7 is followed. Cardiorespiratory support, dialysis for renal failure patient may be required in few critically ill children. About specific therapy, do not delay first-line treatment if HLH is diagnosed and suspected with high H score in patient with at-risk clinical feature. First-line treatment is usually with corticosteroid, where there is concern about concomitant infection and infection driving HLH, cover with appropriate antimicrobial. Do not delay treatment with steroid unless there are definitely contraindications. First line treatment is steroid. Always, we can go for either methylprednisolone. If we are giving methylprednisolone, the dose is 1 gram OD, or we can start with dexamethasone. Consider higher dose of dexamethasone in patient with CNS input. Then we need to gradually step down the dosing of the steroids, and we can add this prednisolone or equivalent after 3 to 5 days. When methotrexate or prednisolone are administered intrathecally, evaluation of CSF to be done at the time of diagnosis and after 2 weeks. If there is a clinical evidence of progressive neurological symptom or abnormal CSF, additional CSF CNS therapy is initiated with 4 weekly intrathecal injection. CNS involvement diagnosed by CSF for spread or imaging finding can prove detrimental owing to long-term deficit, neurological complication, and requires aggressive treatment with weekly injection of intrathecal methotrexate or hydrocodone. In addition, HLH chemotherapy to be administered until no abnormality is detected in CSF and symptom disappear. Dexamethasone helps in reduction of CNS involvement, partly by penetrating blood-brain barrier. Involvement of CNS is predominantly suggestive of genetic etiology, and risk of significant long-term morbidity is high. It has been advised to consider hematopoietic stem cell transplant for such a patient. Second line therapy is Anakinra, which is a recombinant interleukin 1 receptor blocker. Since interleukin 1 is the important initiating agent in cytokine cascade, blocking its activity is logical therapeutic strategy. Anakinra is the indicated for steroid refractory HLH due to all causes presenting in people of any age in whom first line therapy with corticosteroid has not been effective. Use of Anakinra for HLH is off-label and is administration by intravenous route. In critical illness, intravenous dosing is often used to achieve higher and faster maximal plasma concentration. Dosing involves starting with at least 1 to 2 mg per kg per day, increasing to maximum 8 mg per kg per day in both adults and children. If there is inadequate therapeutic response, advice from specialist center which regularly manages HH. In practice, starting dose is often 2 to 4 mg per kg IV, rounded up to nearest 100 mg in 2 to 3 divided dose. This can be titrated to maximum of 8 mg per kg per day in divided dose. If more than 100 kg, dose should not exceed 800 mg daily. In case involving severe renal impairment. Now regarding subcutaneous injection of Anakinra. Anakinra is given subcutaneously unless contraindicated or unsuitable. Anakinra prefilled syringe are sterile, unpreserved solution and for single use only. Do not shake the bottle. Allow the prefilled syringe to reach room temperature before injection. Before administration, visually inspect the solution for particulate matter and discoloration. Only clear, colorless to white solution that may contain some product-related translucent to white amorphous particle should be injected. The presence of this particle do not affect the quality of the product. To be administered subcutaneously to the abdomen, top of the thigh, upper outer areas of the buttock, in the outer areas of upper arm. Intravenous bolus dose of Anakinra. Intravenous bolus administration is reserved for patients for whom subcutaneous injection of Anakinra is unsuitable. That is platelet count of less than 20,000 or if who are critically unwell and have subcutaneous edema. Recommended doses as I mentioned before, uncap the desired number of pre-filled Anakinra syringe, then add appropriate dose of 50 ml or appropriate dose to the 50 ml syringe, making up total volume of 50 ml with sodium chloride and infuse over 30 minutes. Then response criteria, at least one of the following should be present. Reduction in the level of organ support, serial reduction in H score, reduction of ferritin level by at least 10% within 10 days, 7 days, where applicable, the reduction of corticosteroid dose by at least 25% within 40 days. Now about stopping criteria. If there is severe adverse event like anaphylaxis, no evidence of clinical response according to response criteria above within 14 days, resolution of HLH defined by local and national MDT discussion. Now about intravenous immunoglobulin. Intravenous immunoglobulin may be considered in refractory HLH, particularly if there is cardiac and CNS involvement. IVIG is expensive therapy in short supply, and the use is therefore controlled by NHS England guidelines. In HLH, IVIG should only be considered after local and national immunity discussion and in the context of steroid and Anakinra refractory HLH. IVIG can be given in an emergency situation and permission sought from IVIG panel. IVIG is contraindicated where hyperviscosity is the risk, and in the case, the urgent discussion with hematology on-call team is required. IVIG dosing is 1 gram per kg per day for 2 days. Consider repeating same dose on day 14 after discussion with multidisciplinary team with HLH relapse or remain steroid dependent. Now about cyclosporin. Cyclosporin is useful particularly in HLH triggered by rheumatic disease as well as in preventing relapse HLH more generally. Usual dose is 1 mg per kg BD, either PO or IV. Etoposide is chemotherapeutic agent prescribed by hematologist only. Etoposide may be considered in steroid or unkinra refractory HLH in discussion with hematology consultation. The usual dose of HLH for HLH is 150 150 mg intravenous twice weekly for 2 weeks in first instance, but dose reduction is often needed because of liver dysfunction. Etoposide may be available as an oral medication depending on local prescribing arrangement and should be discussed with local hematologist. Regarding continuation therapy, initial therapy is continued with the aim to keep disease inactive for 9 weeks to 40 weeks. It is advisable to continue therapy in non-familial disease and no genetic evidence of HLH, only if the disease is active after initial therapy. In case of genetically proven HLH after initial therapy, once the disease is under control, hematopoietic stem cell transplantation is mandated. So this is the summary of the treatment that we can be that uh, and we are following in the HLH. So the drugs are we can use etoposide 150 mg intravenous twice a week for 1 to 2 weeks. Then we can go for dexamethasone 10 mg for initial 10 mg per day for initial 2 weeks, then 5 mg and gradually reduction of the dose to 2.5 mg and 1.2 mg. Then we can also use cyclosporine, initiate at 6 mg per kg daily if kidney function is normal. Then we can administer methotrexate intrathecally and prednisolone intrathecally in children. For maintenance dose also, we can use etoposide, dexamethasone, and cyclosporine. So, if we are planning to use etoposide, then 150 mg intravenously every 2 weeks. Then dexamethasone pulse dose every 2 weeks and 10 mg for 3 days. Cyclosporine dose is adjusted to achieve blood level of around 200 mics per liter. Then regarding stem cell transplantation. In primary HLH, which is genetically proven, allogenic stem cell transplant is only curative therapy. For stem cell transplantation, HLA identical donor is preferable. The risk of sibling carrying the disease must be considered, and carrier state is less likely if older sibling is considered as a donor. But this age criteria cannot be used as indicator for being non-effective. In the absence of genetic marker, NK cell activity can be considered as a surrogate marker of immune dysfunction. In situation of non-availability of HLA identical relative, stem cell transplantation with match unrelated donor is recommended. If there is no matched donor available, the mismatched donor or cord blood is suggested as decided by physician. The therapeutic outcome with mismatched donor are improving in recent past. Stem cell transplantation is considered in primary HLH once the disease is under control after initial therapy. Now, new approaches in the therapy. Despite all aggressive measures, it is difficult to halt progress of HLH. Despite not everyone can undergo stem cell transplant. Here, new approaches to salvage such a patient are under trial. Combination of etoposide with antithymocyte globulin looks like an interesting and promising option to improve the outcome by increasing initial response and maintaining them until hematopoietic stem cell transplant can be performed in primary and refractory cases. Plasmapheresis to remove excessive cytokine has been performed in few with temporary benefit. Various monoclonal antibodies such as alemtuzumab, infliximab, and daclizumab has been described in various case reports with appreciable success rate. Alemtuzumab targets the CD52 antigen, which is expressed on most lymphocyte, monocyte, macrophages, and dendritic cells. Infliximab and the daclizumab target TNF and CD52 respectively. Rituximab has been used in EBV-triggered HLH through the varied success rate. Splenectomy and liver transplant for refractory cases has been proposed with limited success. Being a rare disorder with lack of data, there is still long way to develop the treatment strategy for refractory and resistant HLH disease. More evidence is required before this can be offered as a definitive cure. Thank you, guys.